Again, welcome. The impact of COVID-19 on the African American community, the facts and fiction. My name is Jennifer Willis. I am the first Vice President of Programs for the National Coalition of 100 Black Women, Sacramento chapter. And it is my pleasure to invite you and share with you our wonderful presentation tonight. I'd like to do a little bit of housekeeping. First of all, let everyone know that I will be putting everyone on mute except for the speakers. Again, we are recording this particular event, and the recording will be available on our YouTube channel, SAC and CBW. If you have questions that are not answered, we would love for you to feel free to type them into the chat. And at the end of the presentation, Dr. Gates will let her know what the questions are, and she'll be able to respond to them. Let's see, any other thing? Okay, so that's it. Let me start by introducing our president, Dr. Elizabeth Sherrill Davis. Take it away.
Thank you, Jennifer. And good evening, everyone. Sending greetings from the National Coalition of 100 Black Women, Sacramento chapter. And I am Dr. Elizabeth Sherrill Davis, president of the Sacramento chapter of NCBW, as Jennifer stated earlier. But before we begin the presentation, I'd like to provide just some history regarding NCBW. We are one of 62 chapters in 25 states, which includes the District of Columbia. We have well over 3,000 members working collectively in the community to provide advocacy in the areas of economic empowerment, education, and health. In CBW Sacramento chapter, we were chartered on November the 10th, 2001, and we comprise of professional African American women. We are dedicated to strengthening the African American community. And some of our programs are economic empowerment. We have programs on financial literacy. In regards to education, some of our programs consist of the summer reading program. We have a STEAM, science, technology, engineering, arts, and math. And we also provide scholarships. We have two mentoring programs. One is our Fostering Hope, and one is the STEAM, the science, technology, engineering, and arts. Both are mentoring programs. Before I close, I wanted to share with you our NCBW's core values, which is gender equity, inclusion, respect, social justice, integrity, accountability, economic empowerment, and collaboration. For more information about our programs or to make a donation, please visit our website at ncbwsacramento.org. I want to thank you all for being here this evening.
You'll be back in line?
And now I'm going to turn the program over to our education chair, Dr. Adrienne Lawson.
Thank you, Dr. Elizabeth. Welcome, everyone. Good evening. I have the great pleasure to introduce our speaker for this evening. Dr. Kristen Gates graduated from the George Washington School of Medicine and Health Sciences in 2011 after completing her undergraduate degree at Xavier University of Louisiana. She completed her medical residency in Connecticut, and she is board certified in family medicine. She and her husband are originally from Chicago, and she began working as an adult primary care provider for Kaiser in Elk Grove in 2018. Prior to working at Kaiser, she practiced medicine in Connecticut and served on the Connecticut Hospital Association Health Equity Advisory Council. And she also co-chaired the Diversity and Inclusion at Middlesex Hospital in Middletown, Connecticut. She is currently serving on the African American Health Disparity Strategy Team for the Kaiser South Sacramento region. She and her husband recently celebrated the birth of their first child, Renee Michelle. Congratulations, Dr. Gates, and welcome.
Thank you, and thank you so much for that introduction as well. You guys let me know if you can't hear me, and we will certainly dive into this presentation. So I'm excited to be here. Definitely want to make sure that we cover a lot of the topics that we've got planned for today, but leave some time so that we can really answer any questions that you guys have. So I am at your full disposal. If you guys have a question, don't feel like it's silly or that you should keep it to yourself. That is exactly what I'm here for. So hopefully by the end of this presentation, you feel leaving like you know a lot more, not just about COVID-19, but I know there's a lot of questions about the vaccination. So I'm hoping that we cover all of that this evening. All right, so again, the title of the presentation, and if you could just go back to that first slide, I'll just say the titles as I started saying it. But again, the title is The Impact of COVID-19 on the African American Community, the Facts and the Fiction. And so for this presentation this evening, you can go to that next slide. There's a couple of key things that we want to focus on. One is taking a closer look at COVID-19. So it's asking what are the unique risks facing African Americans due to the COVID-19 pandemic, and specifically how are African Americans doing in Sacramento County. But also taking a closer look at the vaccinations, asking how do the new COVID-19 vaccines work, what do we know about their safety, and what are the side effects of getting the vaccine. So in kind of keeping with the theme, I wanted to throw some statements of fact and statements of fiction. So our first statement is a statement of fiction, and that is that COVID-19 has equal impact on all communities. So actually, when you look at the data, and this is a slide that was actually produced by the CDC, we find that for African Americans, they are 1.4 times more likely to have COVID. So the cases of COVID are higher in the African American community. And these are in comparison to white non-Hispanic persons. So Hispanics are more likely to have COVID. So that's one of the key differences in regards to prevalence. When it comes to hospitalizations, African Americans are 3.7 times more likely to need hospitalization. And when it comes to death, we are 2.8 times more likely to succumb to the effects of COVID. So now looking more specifically to Sacramento County. In Sacramento County, this was true as of last Tuesday. So the total COVID-19 cases in Sacramento County were then registered at just under 78,000. Total COVID deaths were just above 1,000. So when you break that up into what is being experienced by the African American community, we make up 10.8% of all cases and 11.4% of all deaths in Sacramento County. Those numbers end up being, there have been 5,168 African American patients in Sacramento County who have contracted COVID who are African American. And there have been, of the 1,080 patients who have died, 121 of those patients were African American. So these statistics actually bear out somewhat better than the national statistics. So according to the US Census Bureau, 10.9% of the population in Sacramento County is African American. So you see that the cases and the deaths are somewhat close to that percentage. So the next statement of fiction, COVID-19 is as deadly as the flu. And now in full transparency, when this pandemic first occurred, when we were first starting to gather data, we truly did not know the answer to this. We assumed that because we were dealing with an upper respiratory viral infection, that we would see something similar to what we see with influenza. Coronavirus itself typically is not a deadly virus. So coronavirus itself is not new. It's just this specific strain that is new. So the COVID-19 is the thing that is new and hadn't been seen before. And when you look at the data, we find that that is definitely not true. COVID-19 is much more deadly than the flu. Next slide. So when we see here, oh, can you go to that one slide before this one? Perfect. So COVID-19 is at least 10 times more deadly than the flu. So what we found statistically is that 0.1% or less of people who contract influenza actually die from that infection. In comparison, 1 to 3.4% of people who get COVID pass away from complications from COVID. We also have a significantly higher hospitalization rate, whereas only 2% of people with the flu end up in the hospital, 19% end up in the hospital because of COVID. When we look specifically to African Americans in Sacramento County, 2.34% of those who contracted COVID died of the disease. So we can see just how significant the impact is, which is why there has been such a push toward trying to do something to prevent people from contracting it, whether it's social distancing, wearing masks, washing hands, or vaccination. That is the reason why there's such a desperation to prevent the spread of this disease. Next statement of fiction. I don't need to get vaccinated now. I can just wait for others to get the vaccine in order to be protected. So this is a really great question. And it would seem like as long as enough people got the vaccine, that those people who either had concerns about the vaccine or were worried about side effects or just felt uneasy about the speed in which the vaccine was created, that as long as other people felt comfortable, that they themselves could possibly be protected. And what I want to take a moment is to kind of talk about herd immunity. So herd immunity is when there's so many people who are immune that the virus doesn't spread easily. So the only way that the virus can spread is if someone has not had the infection or is not vaccinated. That's the only way that someone could contract a viral illness. So when you look at how many people have to be immune to get herd immunity, just comparing other vaccines that we know, when you look at polio, it takes 80 to 86% of the community in order to reach herd immunity. Something like measles, which is one of the most infectious viral infections, takes 90% or more, 91 to 94% to reach herd immunity. What we don't know is how much it'll take for COVID. This has been evolving. So when people like Dr. Anthony Fauci were initially guessing about how much it would take for herd immunity, they were hoping that it would be around 75%. In recent times, that number has increased to saying that it may take as much as 85%. So when we are dealing with these new strains, that's the thing that this really becomes important, because the more infectious the virus, the higher the level of higher the level of people who have to be immune is needed for herd immunity. So basically, this is meaning that everyone would practically need to be vaccinated, or everyone would practically need to have gotten the vaccine or gotten the illness in order to reach herd immunity. So waiting on herd immunity is not a good plan, for sure. Next statement of fiction, and this is an important one, that this vaccine is a government project that is just like the Tuskegee experiment. So there is some important understanding that we have to discuss about the difference between the Tuskegee syphilis experiment compared to what's going on right now. So if you can show that next slide for me. So this is the actual flyer that was sent out to Macon County, Alabama, in advertising for the Tuskegee syphilis experiment. And the flyer read, "Colored people, do you have bad blood?" So at that time, bad blood was a colloquialism. It meant syphilis. People would use the term bad blood to mean syphilis, but they would also use it to mean anemia or fatigue. So there were a lot of things that could be wrapped up into that term. Syphilis was just one of those possibilities. So what they were offering were free blood tests and free treatment. And it was given by the county health department and government doctors. The statement says, "You may feel well and still have bad blood. Come bring all your family." And then list the day and the times and locations of where this would be offered. So the biggest failure of the Tuskegee syphilis experiment, outside of its atrocity, is the fact that what they advertised to the patients was treatment, when what they were really doing was watching the course of untreated syphilis. And even when penicillin became available as a treatment in the middle of their study, they prevented the men in their study from obtaining the cure for syphilis. So in a clear difference between what we're dealing with the vaccines is one, this is not an ongoing experiment to see where, to see the results purely of, to see the results of an untreated illness. So what we are dealing with instead is a transparent and honest approach about what we know and what we don't know. And I think that that's super important. Go to that next slide for me. So what is really true is that atrocities like the Tuskegee experiment are impacting African-American patients' decision about whether or not to get the vaccine. So I want to bring up one point. One of the things that sometimes gets misrepresented about the Tuskegee syphilis experiment is that people believed immediately when the story broke in the 70s that these men had been infected with syphilis. And that actually was not the case. What happened is that they already had syphilis, but they were prevented from treatment. So it was not this trial to where African Americans received an injection. But that misunderstanding of what happened, in addition to having multiple valid reasons to not trust the government, would make sense why there would be this hesitancy about getting the vaccine. So when you look at the research, and you can go to that next slide, there actually is a lot of early studies or early surveys that are showing that many African Americans have a hesitancy about getting the COVID-19 vaccine. And the reason why this ends up being so critical for us to talk about is because we saw the early statistics that we were 2.8 times more likely to die of COVID than our white counterparts. And so when we're refusing the vaccine, it's a much more dangerous refusal. At Kaiser, the Kaiser Family Foundation in December conducted a study, and they found that 35% of Black adults said that they probably would not get or definitely would not get the COVID-19 vaccine. And they also found that 48% of the African-American patients that they surveyed stated that they were not confident that the vaccine was taking the needs of Black people into account. So what my hope is today is not to convince you to take the vaccine. What my hope is to provide you with the information needed to make an informed decision for you, and as well as to have an informed conversation with those you love. Next slide. So in order to do that, we have to really understand these two vaccines. So I want to take a closer look at the Pfizer and the Moderna vaccines. These are the two COVID vaccines that are currently available. Next slide. So the next statement of fiction. the steps of the normal clinical trial process were skipped to accelerate the production of these COVID-19 vaccines. And this is really important for us to talk about. So the steps actually were not skipped, but they were accelerated. So what normally happens when you're talking about a vaccine trial is that you start with your preclinical trials, and you get enough money in order to investigate phase 1. If phase 1 is successful, then you can apply to have additional funding or have investors give you money to continue to do phase 2. Again, similarly, you have to show success before you get funding to do phase 3. So what happened in this case was that because of the dire need that we see with COVID, again, going back to that comparison to the rate of fatality with COVID versus flu, once that became very apparent how deadly of a viral infection we were dealing with, you had governments being willing to front all of the money necessary to create a vaccine up front. So there wasn't these momentary periods to where you had to have proof of having success before you could go to the next step. That doesn't mean that there wasn't evaluation at each step. So the easiest way that we sometimes explain it is, you know how for to build a new home normally will take months, but you'll see these extreme makeover home shows to where they'll build an entire house in only a few days. And the reason is because they have increased personnel and increased resources. And that is essentially what happened with our vaccine trial. Next slide. So the next statement of fiction, these vaccines weren't studied in Black patients. So if we actually look at the data here, and you can go to that next slide. So Pfizer had over 40,000 people enrolled. Of that 40,000, 10% approximately were African American. When you look at Moderna, they had about similar ratio, over 25,000 people enrolled in their study, and again, about 10% African American. The reason why these numbers are actually impressive is that if you look at other recent vaccines that have gone on the market, so within our lifetime, well, I should actually say like within my lifetime, so you've got something like Gardasil, which is HPV vaccine. I distinctly remember that coming out during my teenage years. So Gardasil was studied in only 15,000 patients. You have Shingrix. A lot of people will ask me about that. That is the newer shingles vaccine. That was studied in just a little over 29,000 patients. So when you're looking at something like Pfizer, who's got 40,000 people enrolled in their study, that's a really robust study. And that's one of the reasons why there are a lot of medical professionals, particularly those in infectious disease, who look at the data and truly respect the outcomes because it wasn't taken over just a small sample. And more importantly, because we have racial and ethnic diversity, as well as diversity of age, that's what also makes us feel more comfortable about the findings. Next slide. Statement of fact, there is still a lot we don't know about these vaccines, especially any detail that can only be determined with years of monitoring, like how long will this vaccine provide protection? So I want to spend a little bit of time about this particular point. The trials for Pfizer and Moderna were done this summer in June. So we have about 6 going on 7 months worth of data. So what we don't know right now is if you get the vaccine, do you just have to get it once, like the measles? So the measles, you get the measles vaccine, it provides permanent immunity. Is it something like a tetanus shot to where you need a booster every 10 years? Is it something like the flu to where you have to get the flu vaccine every year? That's the thing we don't know because we don't have the ability to have seen it with time. So the question might be, how was it that we were able to conclude that the vaccine was safe? And the reason why there is emergency approval for these 2 vaccines is based on one simple statement. And that is that they were able to prove that the vaccine is safer than COVID. one of the things that we don't talk about a lot is the fact that it takes extraordinary coordination and medical advancement to eradicate a viral infection. Smallpox is one of the few things that actually has been eradicated. So a lot of people have been talking about the 1918 Spanish flu, when that was the last major pandemic. And so a lot of people have looked for reference to that. It's important to let everyone understand that that strain of the flu is still with us. In fact, in some cases, it becomes one of the strains that is offered as protection in the flu vaccine. Which strains happen in the flu vaccine are often based on the CDC's estimation of what's going to be the most popular strain for that year. So the thing that's super important is that COVID-19 likely is not going away in the way that we would hope, meaning like it'll be something that is still something that someone can potentially catch 10, 15, 20, 100 years from now, more than likely, because of our inability to really eradicate viruses. So it becomes this question about what's safer. Is it safer to potentially get COVID, or is it safer to get the vaccine? And what we have proof of is that getting the vaccine is safer than COVID, having been able to watch people for not only days, weeks, but months after getting the vaccine, compared to what I'm seeing even as a primary care doctor and my patients who are still struggling to recover from some of their side effects from having COVID disease. The other thing is that we are continuing the surveillance of these vaccines. So just because the trials ended does not mean that the CDC is no longer collecting information. So this part of the slide here that says VSafe, after vaccine health checker, if you actually have, if you're on your computer and are logged in with your, if you're logged in with your computer and you have your smartphone, you can actually scan that QR code on the screen there, and it will take you to the CDC's website that shows about how you can upload your symptoms after you get the vaccine. So this is the way that the CDC is still getting information from everyday people. I also want to point out the reason why it's so important that we do tiers for vaccination. Again, this is an emergency use authorization. So the first set of people getting the vaccine were your doctors. So I always really honest with my patient. I just got my second dose on the 12th of January. I always tell them that I was a guinea pig for you guys. So we were the ones there was very little data outside the trials when we were the first ones up to get vaccinated, right? And part of that is just because the likelihood that we're going to come into contact with COVID is almost guaranteed. Again, this is not something to where you can live your life not seeing your loved ones, wearing a mask, having gloves 6 feet apart. Very few people can do that for the rest of their life. And so for healthcare professionals, we're going to see somebody who's sick. That's why we were the first people to get it. And this is why they're going by age, because that risk of death is really highest in patients who are oldest. And so clearly the vaccine is safer for them than it is for somebody who is much younger. So now what I will say to everyone is that if someone was 17 years old, so the Pfizer vaccine is approved for 16 and older, Moderna, it has to be 18 and older. If someone was 17 years old and they asked me, Dr. Gates, should I get the COVID vaccine? I would say not yet. It's a little early for me to feel comfortable in someone whose risk benefit isn't as clear. But that is part of the reason for the tiers, because as we move to those lower tiers, we have more and more information about the safety compared to the risk. Next slide. So statement of fact, the method used in the Moderna and Pfizer COVID-19 vaccines is not found in other vaccines. This is true. This actually is part of the reason why it was able to be successful, more than likely with being able to move through the processes sooner. So now, even though the technology is new, I need to clarify what new means in this case. So what the Pfizer and the Moderna vaccines are mRNA vaccines. So mRNA stands for messenger RNA, and RNA is basically a blueprint to your cells to tell it how to make a protein. So what this is doing is giving your cells the blueprint to make just the infectious part of COVID-19. So a lot of times what happens in your traditional vaccine is that you take a virus, you kill it, you give the dead virus in a vaccine so your body recognizes that virus and has an immune response. This is different. Instead of giving you a picture of the virus, you're actually giving your body the blueprint of the virus. So some things that are super important to understand. mRNA vaccines do not use live virus, so you can't get COVID from the vaccine. There are like some flu vaccines like that go through the nose that are a live virus. The measles, mumps, rubella vaccine is a live virus. This is not a live virus. It has no virus in it. Again, it's just the blueprint. It's not the actual virus. mRNA does not get into our DNA in any way. Basically, the body throws away the blueprint, discards it the moment that it takes the information to make the protein. So does not get into our actual cells at all. You can go to that next slide. So we've all seen this picture of COVID-19. So you can see those, the kind of the spikes coming out of the circle. Those spikes are actually called a spike protein. And this is what COVID-19 looks like if you were to take it as an image, like from under a microscope. And so this is kind of a 3D version of that image. And so what is being replicated are these spike proteins. Now, the spike protein is critical for COVID-19 to cause an infection. So it's unique to COVID. Actually, COVID, of course, standing for is what we use for short for the generalized terms of coronavirus 19. So corona means crown. So the reason why they used the term corona was because they felt like all these spikes looked like a crown. And so that spike protein is this unique feature of coronavirus. So because this is a unique feature, it's seen as foreign from our immune system. So our immune system, when it sees it, it knows, hey, this is not something that normally should be here. This is something that our immune system should be prepared to attack. And then it creates a memory so that the next time it sees it, your immune system is already ready. So just going through these steps really quickly here. Again, the vaccine gives the cells mRNA, the blueprint to make one of these proteins. Your cells create the COVID-19 protein. So that would be the construction. The immune system learns to attack the protein. I compare that to the floor plan. So if any of you have looked at like new houses, one of the things that you'll see is you could pick the same floor plan, but have a house that looks completely different than another house with that same floor plan. Basically that it has a different elevation is what they call it. And so this is one of the reasons why we think we're seeing success with the vaccine, even though the virus is mutating, because our immune system is not looking at a picture. So you can take the same blueprint, right? Have a different outside appearance of the house. But if your immune system is targeting the actual structure, then it makes it less susceptible to mutation. This had been something that they were already starting to try and study for possible other vaccines. And it just so happened to be a perfect storm to where this technology had already been studied. And then the unique feature of the coronavirus having these spikes just made it possible, as well as all of the money that poured in to try and develop this vaccine so quickly, gave a perfect scenario for scientists to come up with a vaccine using mRNA technology. And we hope is actually one of the reasons why people who have been vaccinated are still showing immunity, even as we're seeing mutated versions of coronavirus. You can go to the next slide. So statement of fiction. After you've had the first dose, you are already protected. The second dose is just a booster. This is a very important piece of fiction to understand. You can go to that next slide. So the first dose just primes your immune system against the virus. The second dose is the one that protects you, but it still takes 1 to 2 weeks after the second dose for full protection. So when you hear these stories about there was a nurse or a doctor who got COVID in between their first and second dose, that's not surprising because they're not protected. There's no protection until at least 1 to 2 weeks after the second dose. So when you hear all of those studies saying that Pfizer is 94% effective, that Moderna is 95% effective, they didn't check how effective it was until 1 to 2 weeks after the second dose was given. What we know is that one dose for sure is not enough in order to have an immune response. Both of these vaccines require 2 doses, and you have to get the second dose. It has to be from the same manufacturer as the first dose. So you can't get a Pfizer vaccine first and then take a Moderna vaccine. Whatever you start with, you have to end with, because there have been no studies mixing and matching the two. Statement of fiction. After you get vaccinated, you don't have to wear a mask anymore. This is another really important thing to underscore. So the studies that looked at the effectiveness only looked at whether or not the patients who got the COVID-19 vaccines, whether or not they got COVID. They were not able to study whether or not someone who was immune from getting sick themselves was unable to spread it to other people. So even after someone is vaccinated, they still have to wear a mask, they still have to keep distance, they still have to wash their hands. So that is the part that we don't know, is whether or not the vaccine is truly protective of others. So even though many of us here at my office have been vaccinated, nothing has changed with how we operate in the office. We still wear masks, we still stay 6 feet apart, we still are frequently washing our hands, although that's pretty standard in medicine. But all of those different things happening because of COVID, they stay exactly the same. What getting the vaccine has done for me is lessened the likelihood that I myself can get sick from COVID. Next slide. So statement of fiction. Getting a COVID vaccine is just like getting a flu shot. This is definitely not true. And I made the mistake of believing this. So the COVID-19 vaccine is, you know how people will say that they got sick after they got the flu shot? You will get sick after getting a COVID-19 vaccine, especially if you don't prepare. So it causes, for some people, a tremendous amount of pain at the site of the injection. And all of these things last about 2 to 3 days. So it's not horrible, but it can catch you off guard if you weren't expecting it. So it'll be pain, swelling where the injection was. A lot of people will have fever. And now this is somewhat unique. I don't typically see patients have high fevers after a vaccination, but there have been some of our staff that have been out with 102 fevers after getting the COVID-19 vaccine, particularly after the second dose. Because remember, the first one just primed your immune system. Your immune system really is responding to the second one. And that's what most people are seeing. So they'll have fever, they'll have chills. There's a lot of fatigue. Headache is super common. For some of us, we've had like some GI symptoms, mostly nausea. I haven't heard of anyone really vomiting. Nausea has been more common. But you really want to make sure that you don't walk into the vaccine not having taken care of your immune system. You can go to that next slide. So the next statement of fiction is that there is nothing that you can do to help reduce the side effects of a COVID-19 vaccine. So I will tell you, I felt pretty horrible after the first one. My my statement to my husband was that the last time I felt that bad, I was pregnant. And I was like, what on earth is this vaccine? And I was like, they told us that this is like a flu shot, but I should have known that wasn't true because we couldn't all get it at the same time. So we were staggered as an office, as a department. You couldn't have everyone in one department get it on the same day. And that is because you need people to still be able to go to work and take care of patients. We can't all be sick at the same time. So the way that you can prepare your body for the COVID-19 vaccine, and these were some of the things that I did, and I felt, ironically, I did much better with the second one, which is not as typical, but it's because I did these steps. So you want to sleep at least 7 hours the night before getting the vaccine. You want to stay away from sugar. Sugar sticks to the white blood cells that fight infection, so it makes it harder for your immune system to work. You want to take vitamin D or increase sun exposure by at least 15 to 20 minutes a day. There are a few studies out there that have found having adequate vitamin D seems to be beneficial to the immune system, and that people who have had vitamin D deficiency have had worse outcomes with COVID. So taking vitamin D is very important, especially for us as African Americans. You want to take vitamin C. Not only does it help immunity, but it also reduces inflammation. And you want to take zinc and echinacea, because there are some studies that, again, that they tend to help the immune system, especially when you have them early. So what I did was I slept at least 7 hours the night before, which is a lot for me because I normally stay up really late, but not this time. For sure, I got my 7 hours of sleep. And then I took all of these supplements before getting the vaccine. And then I also did that after. And so with that, I had much fewer symptoms than I did the first time. Next slide. So with that, I'm going to open it up to questions. And so this way we can certainly dive into if there are any other questions, concerns that you guys have, especially anything that you felt like didn't get answered from the information that I provided with this presentation.
Thank you, Dr. Gates, very much. Hand clap for her or thumbs up emoji. We have a few questions. Am I assigned to do the questions? Say the questions? Just want to make sure I'm not taking someone else's job. Okay, I'll go ahead with the first question that we have in the chat. Is, sorry, I have it in a Word document actually. So the first question is from, I think it's Derry. How come it's taking so long to get vaccinated as a patient?
So one of the things is the need for supply, right? So this is one of the few situations to where every single person is needing a vaccine at once. That is certainly a big component of it. The other is the fact that it takes 2 doses. So you cannot vaccinate someone without guaranteeing that you can also provide them with a second dose. So a lot of times when, like for example, the news will publish how many doses have been given to the state of California, you have to divide that in half, because half of those doses have to be the second dose for the person who started the vaccine. So what happened with all of the confusion that's happened over the last week was that the government suggested, hey, we actually have more vaccine coming, just give everything you have as a first dose, because we're going to get you enough to make sure that you have enough for the second dose. So that's when people started to drastically change their approach in vaccinating, but then there ended up not really being that supply coming through. And so there's a lot of concerns about the supply chain because again, you have to get your second dose 21 days for Pfizer, 28 days later for Moderna. And there's a 4-day grace period. It's okay if you get it later than that. It's not ideal, of course, right? But you don't have to start the series over if you go later than 21 days for Pfizer or later than 28 days for Moderna, but you can't get it more than 4 days early. So that is what's creating it taking so long. So I got my first vaccine right a few days before Christmas, and I wasn't able, of course, to get my second dose until 2 weeks into January. So you're talking about a month for most people because of that 3 to 4 week period before someone is actually fully vaccinated.
Thank you. The second question is from Lanisha Williams. Are there any cases of a patient getting 2 doses of the vaccine and then later developing COVID-19?
So there is no vaccine that's 100% effective. When they were trying to get this vaccine, they were hoping for it to be 75% effective. So the fact that it's 95% effective is really, really encouraging. And it is probably because, again, the vaccine is targeting that spike protein. But is it possible potentially for someone to get COVID-19 later? Yes. So possibility, without question, is possible. According to the data we have right now, is it likely? Is less likely. But again, you got to remember, it doesn't have full effectiveness. It doesn't reach that 95% level until 1 to 2 weeks after you've gotten that second dose. So, we're essentially talking easily 6 weeks from your first dose before you can truly say that you've got full protection, at least full protection that the vaccine can offer.
Thank you. The next question is from Sharon Saffold. When can a person who has tested positive for COVID-19 receive the vaccine?
So that's a great question. According to the CDC, the bare minimum is that you have to be done with your quarantine period. So if someone's done with quarantine, then they technically can get the vaccine. When I'm talking to my patients, I want them pretty much back at their baseline before getting the vaccine, because someone who has had COVID is pretty well accepted in medical literature from the studies that we have, that person has about a 90-day protection from getting COVID again. The antibodies, which is the body's immune system that specifically fights a particular virus. So the antibodies that someone has to COVID-19 are high for at least 90 days. So we don't even retest someone for COVID if they're 90 days within their last of having a COVID-19 virus. So, or a COVID-19 illness. So what I would say is that truthfully, there's not a lot of rush in that first 90 days. So there are some people who will say, you're already have some level of protection. Your immune system is already somewhat primed. It may make more sense to get the vaccine once you're beyond that 90 days as your immune system is waning. But technically, someone wouldn't have to wait. They would only have to wait until they're done with their quarantine.
Okay. I think that answered Christine Lovely's question, which is similar. I'll go ahead and read it since she took time to put it in here. I have some family members that are positive for COVID-19 right now. Isn't it true that they can get it again? How soon after recovery should they be vaccinated? If you have anything else to add.
Yeah, I think the real emphasis is really, for me, when I'm talking with my patients, is recovery. So, I have some patients, I have a patient who's young in her 30s, who has no significant medical problems, who ended up hospitalized and on oxygen with COVID. Mm-hmm. Well, more than, a month out from her infection, she's still being weaned off oxygen. Do I really want her to get the COVID-19 vaccine? I just told you guys what it did to me. I don't think so. I think I want you to be fully 100% healthy so that your immune system can really respond, right? It's kind of like you wouldn't put yourself through training for a marathon with a sprained ankle. It just doesn't make sense. So you want your immune system to be recovered so that it can have the best response to the virus so that you're more likely to have the full benefits of going through that vaccination.
Thank you. That was very helpful. The next question is from Marilyn Stockdale Coleman. Is there any reason why you would advise against getting the vaccine if you are 55 plus?
So there are essentially two categories of people who shouldn't get the vaccine. And one is a group who's allergic to polyethylene glycol, which is a component in the vaccine, which I'll be transparent. We had a presentation from our allergist. Almost no one has that known allergy, but just in case there's someone on earth who knows that they're allergic to this, then they shouldn't get it. But it doesn't have the common things that people are allergic to, like latex, like that's not included. There's no egg in this vaccine. So a lot of the common allergies in a vaccine are not included in this one. There's some hesitation for people who have had anaphylaxis, so meaning hives and you can't breathe and you needed an ER visit. Someone who has that kind of reaction to any injectable medication, they technically can still get the COVID-19 vaccine, but they have to be monitored for 30 minutes after the vaccine rather than the standard 15 minutes. So that's the other thing about this vaccine. It's a more involved process. You can't just get it through a drive-through and be gone. You have to get it and sit there for 15 minutes being observed. And technically, where it's being given needs to be able to get you to medical attention should you have an allergic reaction. So the biggest group of people who can't get the second dose are people who had a reaction to the first dose. But outside of that, if you're being, realistic, because there's not even an allergy test for polyethylene glycol. So to just put it in perspective, like there's no way that someone who doesn't know that they're allergic to that, hasn't had an experience, they really don't need to be tested to see if they are allergic. It's just something that they put because they know it's a component in the vaccines. So they don't want somebody who happens to know, but it would be a very highly scientific situation that probably would have taken years of testing to pinpoint that. Long story short, pretty much the only people who can't get the vaccine are people who had an allergic reaction to the first one. That's realistically the only limitation. And somebody who's under 16, because it hasn't been studied in children.
Great, thank you very much for that. This question is from Deborah Ellison. What are the side effects that have been reported from others who have gotten the vaccine?
So a lot what I was saying before, fever. There are a couple of people who have had cough, which is surprising. But again, these normally don't last more than 72 hours. If they do, what we're told and instructed as providers is to be tested for COVID if we're really dealing with something that's lasting more than 48 to 72 hours. But just to repeat what I said earlier, is fever, it's a lot of soreness at the injection site. So it feels worse than a tetanus shot. There's a lot of soreness in the arm. There could be some swelling where the injection was feeling fatigued, headache. Like I said, nausea is something anecdotally that a lot of people have said, my fellow colleagues. Some people have had body aches. So basically, a lot of the symptoms that people describe with the flu, people often have had with this vaccine.
Gotcha. I have a follow-up question to that. I recently had the shingles vaccine, I think back in October, and my arm was very sore. So are you saying it's similar to that? What would you recommend, an ice pack or aspirin?
So ice would be great. We like Tylenol just because it just tends to have less medical risk. There are some people who just can't have anti-inflammatory, so Tylenol is just a little bit safer as a universal statement to make to everyone. Using both of those would be appropriate. I would put money that the COVID vaccine hurts more than the shingles vaccine. So normally tetanus, because again, tetanus causes muscle spasm. So like that's what the tetanus infection causes. So normally the worst arm pain is with a tetanus vaccine. And since I just had my daughter, you have to get a tetanus booster when you're pregnant. So I just got tetanus. So I can tell you guys, this is significantly worse than the tetanus vaccine. So, and the tetanus vaccine is normally considered the worst for arm pain. So Yes, this arm pain is much worse. But to your point, this is a different point that's important. You can't have another vaccine within 14 days of when you're scheduled to get a COVID vaccine. So you couldn't get a flu shot the day before and then get COVID. Again, and that goes to the idea that your immune system needs a clean slate. It can't be preoccupied trying to develop an immune response to something else. It needs to have its full attention on trying to respond to this vaccine.
I just have one more follow-up question to that. Why is there so much pain for that? That's just the way all booster shots are, or is it the level of um, the vaccine in it, or I mean, what is it? What causes that pain?
So the injection is irritating to the muscle, right? So ideally, like we wouldn't normally have anything injected into our muscles. So when it's there, it's going to cause some irritation. The same way, like if you put a rock in your shoe and started walking on it, it's not supposed to be there. So for some, that causes greater inflammation than others. So you got to look also at what the virus does, right? And so I usually think that the more severe the illness, then the more potent the side effects to that particular vaccine. And that's just purely anecdotal, but again, like how hard is your immune system going to have to work to respond? And so when I'm telling you that it's at least 10 times more deadly than the flu. And in Sacramento County for African Americans, it's 20 times more deadly than the flu, because it was 2.34% of African Americans who have contracted COVID in Sacramento County have died. Right. And it's 0.1% fatality for the flu.
If you miss
so when we're talking about that kind of difference, it's going to be quite an immune response, right? That's not a mild illness.
This question is from Rosemary, and I think you answered it, but if you have anything else to add, will you have to take a booster injection on an annual basis?
That's what we don't know, and I sure hope not. I really do not want to get this every year. I'm going to be 100% transparent with all of you guys. I don't want this every year. I hope not. But we will only be able to tell that with time. We will only be able to see those 40,000 people on the Pfizer vaccine trial, those 25,000 in the Moderna trial. Are they still not having infection? And truthfully, any of us who get the COVID vaccine, to a degree, we are all kind of living through how long does this last in real time. That's what we don't know.
Yeah. Well, Martha Tate Glass has a very good question, and I actually wrote this down, so you can have my notes, Martha. Her question is, can we get the information on things to do before getting the vaccine in writing, maybe a PDF to those who are registered?
Yes, this is Jennifer. We can certainly send that out. Thank you for asking that question.
And I think we answered Carol Mullen's question, how long should we wait? She said 14 days. Is Dr. Gates still on?
Yep, I'm still
okay. Is that correct? How long should you wait to take the vaccine, such as the flu or the shingles? That was my question.
So great question. So I'm going to answer this in two ways. So technically, the only issue is about having some other vaccine before you get COVID, right? So when you're looking at it, you're going to need to take 3 to 4 weeks before you can get the second shot. So technically, could you get another vaccine in the middle of your 2 COVID vaccines? You could, but that probably wouldn't be the recommendation that I would give my patient. Because again, anytime that your body is fighting, right, it's always like, I always think of, those old movies with knights in shining armor, to where you see someone guarding the castle, and there are all of those people on top of the drawbridge, and then someone will set off some distraction, and then some enemy can just walk through the front door. That is essentially what often happens. This is why people think that they get sick from the flu shot. The flu shot doesn't make them sick. The flu shot is a kill virus. So it can't give you the flu, but your immune system is now preoccupied. So we give it in cold and flu season. So there are all of these other viruses out there that can just walk through the front door because your immune system is distracted, especially if it doesn't have the tools it needs in order to fight. So would I be testing my immune system when I'm not fully protected against COVID in the middle of getting my COVID vaccine? No, I would not. And I wouldn't advise anybody in my family to do that or any of my patients. I probably would want getting the COVID vaccine to be the only thing that I needed to worry about for my immune system, as much as I could control personally, from the time of my first shot to 2 weeks after I had gotten the final, 2 weeks after I had gotten the final dose.
Makes a lot of sense. I'm glad I already got the shingles vaccine some months ago.
Exactly.
This is a good question from Kimberly Jeffries. Are there any racial and or social economic disparities of those who are getting the vaccine? Are counties like El Dorado County or Yellow counties better off?
Great question. What we are seeing is, unfortunately, people who, particularly some of our African-American staff, even one of my colleagues who's a fellow Black doctor, she's like, I'm gonna wait, Kristen. I don't know if I want it just yet, right? So what we are seeing is kind of going back to those statistics, where when it came to a racial group, when the Kaiser Family Foundation did their survey in December, we were the highest racial group that said that they probably would not or definitely would not get the vaccination. And so, as you guys can see with the supply and demand, right? This is kind of like do you want it? Yes, no, okay, moving on to the next group, right? I think it's really hard to decide to get it after your time has passed, because then you start to have to compete with other groups. So we were still trying to get non-Kaiser healthcare workers vaccinated when all of a sudden the state was saying they were going to try and open it up to 65 and older. Well, now our focus shifts from the healthcare workers who haven't been vaccinated to them plus people who are 65 and older, right? And so I think what is essential is that making a decision is just realizing that when someone's time comes to be available to get the vaccine, that you could have a harder time trying to get it once other groups are also open to it. So that's the only thing that I would say.
Oh, I have a question.
Mm-hmm.
How do we get the vaccine? Do we just go to our primary care physician or sign up? Can I get on the list? How's that working? Great
question. So normally what happens with a vaccine is that your health care provider, their facility, if they're a private doctor, them personally, they purchase the vaccine from the manufacturer in a normal situation. There is not a single healthcare institution who has purchased this vaccine. These vaccines are purchased from the federal government. The federal government then allocates a certain number to the states. The state then allocates a certain number to counties. So there is no way for example, for Kaiser, we have, and I forgot the number total, but in Northern Cal, I think that we have well over 5 million patients who are over 65. And we don't have anywhere close to that in regards to the number of vaccines we've received, right? And so you can't say this 65-year-old is eligible and this 65-year-old isn't. So what we've been forced to do is to say we're limiting it to 75 and older right now, because the older you are, the greater your risk of death is. But there's no waiting list because we aren't purchasing it. So we can't promise something that we can't supply. So what we've been doing is a week by week basis saying where we're at. Now what we're doing is we're outreaching people who are eligible, so our 75 and older, outreaching them. If they want it, then we're getting them hooked up with a visit, like an e-visit, an electronic visit online in order to answer some screening questions, again, to check about eligibility, about the vaccine. So have you had another vaccine in the last 14 days? Those kinds of questions to be able to know if we can proceed. So it's a really frustrating reality without question, but some of this is completely just dependent on when there's more vaccine available. And I think that this is going to kind of go like testing. You know how the beginning of the virus, like you couldn't get a test anywhere. When I was here in July, I was joking with my patients that I felt like I was trying to book like Beyonce tickets. Like I felt like COVID tests, like I would be in the system and right when I'm about to book it, then that test disappeared. I was like, this is absolutely crazy. But now we have far the number of people who need a COVID test. And I can usually easily get them a test the same day or the next day. And it's because the ability and the supply of testing has increased. So the one thing that I'm optimistic about is that eventually the supply is going to increase. But there's just nobody who can honestly look you in the eye and tell you when that will be.
So someone like me that's in their early 50s, I should expect to get the vaccine maybe this summer it'll be available? Can you
So
estimate?
great question. The other limiting factor is the fact that, again, it's all depending on supply. Right now, it's been going so slow because you needed to be accountable to have enough to give somebody both doses, right? And so if there's enough supply to where you can just give everybody a first dose and worry about the second dose later, then people are going to be able to move faster. So it also depends on if they introduce another vaccine on the market, right? So Pfizer can only make so many, Moderna can only make so many. So the more vaccines that are approved, then that also impacts the supply chain. That's the part that we don't know. But is it reasonable to think that it's going to be sometime in the summer, knowing how many 65 and older that we have, and what that's going to take? I don't think that that's an unreasonable expectation, being honest, because we haven't even, like, they may say that it's open to 65 and older, but I can tell you most people are not able to meet that statement. So we haven't truly begun 65 and older. We're basically just starting with 75 and older for most health institutions.
Wow, thank you very much. There's only a couple more questions, but I do want to let you know that everyone's saying how informative this presentation is. And thank you, great presentation, excellent. Great examples, Dr. Gates. So you're getting a lot of kudos in the chat here. I have a question from Kimberly. She's asking, how long after the vaccine are you able to return to work, assuming that you take Tylenol and an ice pack afterwards?
You know, it varies. To put it in perspective for you guys, I got the award for perfect attendance. That's a low-hanging fruit award, you know, full disclosure, right? But basically, I don't miss work. I was about to call out after that first dose, but it was Christmas Eve. I was like, what's it gonna look like if I don't come to work on Christmas Eve? So I toughed through it, and that was the third. I got it on an evening, so I got it after work on a Tuesday evening. Had a headache all day Wednesday, and just woke up feeling, I felt warm but not a fever. And I just had body aches, just like I needed to stay in bed. But, you know, it was Christmas Eve. So for me, that was the end of my symptoms. By that afternoon, I felt much better. So Most people are looking at 1 to 2 days, normally after their vaccine, especially just depending on what time of day they got it. But somewhere around two total, 48 hours, essentially. 48 hours is really what most people are looking at, 48 to 72 hours.
Oh, thank you.
But as long as someone doesn't have a fever, so not a temperature of 100.4 or higher, technically they can return to work. It's really the fever that makes someone call out, unless they just feel too sick because of their body aches or things like that to function. So I didn't have a fever, so I wasn't mandated to not show up for work.
Gotcha. I guess this could be our last question from Kamara. This is a very interesting question. Are there any known cases where a vaccinated person has spread COVID?
So the thing that's so hard is to know for sure where someone got COVID from. Honestly, what would have to happen would be that you would have to have a vaccinated person who has been tested and proven to have COVID, and then have a history that puts them in direct proximity to somebody else who got COVID. So it's not so much that they have an example that suggests that there is somebody who got the vaccine, who didn't get sick, who spread COVID to somebody else. It's just that they did not have that piece as part of their research. So they can't guarantee that that's not possible.
Great. Well, I just want to say I learned a lot. I have about 4 pages of notes and I love sharing information. So hopefully I am representing correctly here. Thank you so much for your presentation. We needed this. We're all wondering what's going on with the vaccine and COVID-19. Thank you so much. And did Jennifer, do you want to close us out? Or are we good? Anyone else have any more questions? We just want to say thank you so much, very much for coming today. And I'm sure other people are going to reach out to you, say, oh, you need to speak over here, over there. We need more people spreading this information. Information is power. So thank you so much. And good night, everyone. Thank you for attending today. We appreciate you.
Dr. Gates, thank you so much. Everybody, thanks for coming. Check back in with us later for more. Take care.
Bye, folks.
Stop recording.